Thank you everyone for joining today's webinar. I am excited to get into the information today. Today we'll be discussing ovarian disease and cancer and whole body imaging. Our speakers today starts with Dr. Vikash Modi, who is a primary care physician by trade and serves with us as the medical director of Preventive Medicine. And we also have Dr. Daniella Kanu, who is one of our head radiologists. And of course, you have myself. I'm Eric Chafe. I'm the head of sales and look after the provider relations team. I'll start off with just sort of a general overview. At the high level, we are a dedicated whole body imaging practice. Today, we have 14 clinics across North America. By the end of next year, we'll be probably closer to 25 plus. Quite exciting update there as we'll be getting into overseas markets, including London, Australia, and some other countries in the EU. Our focus is primarily on whole body imaging. We are the world's first imaging practice focused on this. And today our focus still remains on the routine longitudinal whole body imaging. At this point, this makes us the largest, certainly in the US, doing this with an estimated 10 to 15 times more scans completed compared to our nearest competitor or comparable academic centers of excellence. So this is our expertise, right? We have over 100 members on our clinical team, radiologists, PCPs, NPs, and we're continuing to grow. We're proud to say that our team has played a major role in the technical advancement of MRI application for general whole body imaging, and we expect to remain at the forefront of this movement. As far as our growth and impact, like I mentioned, this is our expertise. We've been doing this for 15 years, conducting whole body imaging with MRI. And this has allowed us to really optimize our protocols over many iterations, improving at a strong rate over this time. So with that, we have the largest data set in the world of whole body imaging based on proactive screening. We've seen the most patients, we collect the most data points per patient. And we hope that forming strong relationships with professionals such as yourselves who care about shifting the paradigm from reactive to proactive will help drive greater positive impact in the world of healthcare. Taking a look, this is a look at our New York clinic. And I think one of the strengths of ours is our complete vertical integration. So we own our clinics. We only conduct whole body imaging from our facilities. Our clinical staff are Prenuvo employees. Our team of radiologists either exclusively read for us or it's the primary reading they do. And they're all heavily trained in whole body imaging. And we think this is a big advantage for us because it really allows us to optimize every step of the patient journey. So again, here's a look at our New York clinic. As you can see, we put a big emphasis on creating a warm, welcoming environment. And because we know for most patients, they might associate MRI with an anxiety of receiving results. In our world, we want to make the idea of disease a lot less scary by catching it early. And we believe that the look and feel and experience of our clinics really help us in doing that. And here's a look at one of our magnets. And for those of you that haven't been through a Prenuvo scan, this might be your first look at MRI rooms. Our magnets are custom built. They're designed to give off a very comfortable and relaxing feel. Our tables have memory foam mattresses. Patients can watch TV or Netflix or listen to podcasts throughout. We scan the whole body in less than an hour. And I think because of this, we have an extremely low rate of claustrophobic patients. Most people come out of the experience actually feeling quite relaxed, which is sort of funny. We take that with pride. So that's kind of at a very high level. For today's presentation, like I said, we're recognizing the fact that September is Ovarian Cancer Awareness Month. So for today, we're really going to dive deep into cancer and disease as it pertains to the ovaries. And at this point, I'm happy to hop off and hand it over to our medical director of internal medicine, Dr. Vikash Modi. Take it away.
Thank you for that, Eric, and thanks for welcoming me back. I've really enjoyed these webinars over the last few months. They have given us a really great opportunity to discuss various health conditions that have traditional screening pathways, but we also have potentially future segments that will include whole body MRI. So ovarian disease in particular is one that's very, very important to me. I have, in my own practice here in Atlanta, treated a number of various conditions having to do with ovarian diseases and ovarian cancer. So I find this topic incredibly important. And we will go through the traditional screening pathways, each of the guideline-based recommendations. And then we're also going to touch on the value that maybe a whole body MRI or MRI in general will have in helping us to really get our hands around these conditions. I'd like to start by first understanding the basics of screening for ovarian disease based on who's eligible and how it's done as of right now. So the first and foremost method of screening for ovarian disease is our pap smears. Screening for cervical cancer with a pap smear remains a grade A recommendation for women every 3 years if they're aged between 21 and 29, or 5 years with HPV screening between 30 to 65. So in general, the population 21 to 65 is who we're recommending pap smears for at this point. However, it's a grade D recommendation, which is actually a recommend against from the USPSTF for women under age 21 or over 65. Those with a full hysterectomy and no history of high-grade cervical cancer are also excluded from those recommendations. So we have a significant portion of our female population who are falling, outside of the recommended gaps. Separately, for adnexal diseases or cancer, I'm sorry to say it's a grade D recommendation from the USPSTF instructing providers not to screen for ovarian disease in asymptomatic women. So for adnexal diseases or cancer, we have no clear recommendations on how to screen for these folks. We are relying on our pap smears and our patient's history and concerns to try and detect these diseases. And as we go through this presentation, we'll understand why that's been problematic historically. Looking at the types of ovarian diseases and masses that we would want to be conscious of, there's of course the functioning cysts, the corpus luteal cysts, the thecal lutein cysts, polycystic ovaries. Incredibly common now in 21st century 2024 America. We're seeing an increase in PCOS rates, and it's really become a little more difficult for us to detect those because the general population's obesity rates are rising, diabetes rates are rising, and symptoms can sometimes be masked. So we have to become a little more keen or aware of what PCOS might look like clinically. And of course, you've got the sex cord tumors, germ cell tumors. The malignancies are a smaller subset of the ovarian adnexal diseases, but far more deadly. Those include our epithelial carcinomas, which make up about 90% of adnexal malignancies of ovarian cancers. And then you've got the epithelial borderline neoplasms and the ovarian germ cell sex cord stromal tumors that are actually malignant. Ovarian cancer, for a moment, we need to dive into this topic because it is so, I think, under-identified in the current U.S. guidelines. Right now, ovarian ranks as the 5th in cancer-causing death for women in America. The American Cancer Society is estimating about 19,680 women will receive that diagnosis this year, almost 20,000 women. And over half of those women will end up passing away from ovarian cancer. And why is the death rate so atrocious? It's because we're not catching these diseases in their early stages as we would in a breast cancer screening or in a cervical cancer screening protocol. Those have routine recommended screening guidelines for average risk patients. Ovarian cancer does not have those guidelines, and so we're not catching them until they're very late, stage 3 or 4. So because it is incredibly difficult to stage it, to catch it at these early stages, and there's no strong recommendations for screening, we're left with this condition that is just eluding current pathways. Ovarian cancer, again, 3 times more lethal than breast cancer, but not if it's detected early. We have really important information that suggests that when caught in stage 1 or 2, we actually have an incredible survival rate. Only 20% of ovarian cancer cases are detected in those early stages, however. So we're letting too many women fall through the gap here. You compare that to breast cancer survival rates at 91%. That's an incredible number. We're incredibly proud of that as a community medically. And we can attribute that to our mammogram protocols, that we are catching diseases earlier, that we are more aggressive, and we identify family risk factors of screening earlier than 40. So we need to start to come back to the table on ovarian cancer and identify how we can catch these folks earlier as well. For the sake of further consolidating our impressions of these other conditions, I've divided them into different approach levels. We have the adnexal masses of almost certainly benign, reasonably benign, versus malignant, and then urgent conditions. Urgent ones are clinically easier to manage, right? that we are going to get prompt medical attention, surgical treatment when someone has an ectopic pregnancy or adnexal torsion. It's the other category, the reasonable and almost certainly benign category, where we have things that are expectant management, and that's when the mass is not suspicious for malignancy. Surveillance is an option if the suspicion of malignancy is low, but there has not been completely excluded. And that includes one or more pelvic ultrasounds, serum tumor markers, which we'll talk about shortly. And then, of course, there is still surgical options for the reasonably benign versus malignant category. And why does surgery exist here? Because of the previous slides. We would offer surgery interventions for something that is reasonably malignant versus benign because the risk of it being malignant is so catastrophic. So that is why surgery, very rarely in other conditions, is now presented as a non-urgent solution to an ovarian disease. While a majority of early stage adnexal masses will be asymptomatic, which makes them very difficult to detect clinically, I've identified a few key symptoms for our providers and patients to help sort of identify if they may be at risk for these conditions. The first ones to be aware of are pelvic pain or pressure, which is the most common symptom associated with the adnexal mass. When present, it is often unilateral. It can be of variable severity, acute or gradual in onset, sharp or dull, constant or intermittent. That is the problem in a nutshell, that there's such a varying shades of these presentations that really it takes a keen clinical eye to identify folks at risk of these conditions to take those next necessary steps. More generalized pain can occur if the adnexal cyst ruptures and spills irritants. So now we got something to investigate once a patient identifies a severe pain that's generalized around the abdomen, lower pelvic cavity, into the peritoneum. Another, of course, symptom to be aware of is abnormal uterine bleeding. More certain types of adnexal masses like pregnancy-related masses, ectopic pregnancies, hormonally active tumors like sex cord stromal tumors are going to give you that abnormal uterine bleeding. And we should always suspect an adnexal mass when a patient presents with those symptoms and take the next necessary steps of imaging and investigation. So throughout this presentation, I'm going to present a case. This is a patient who came to us at Prenuvo just a few weeks ago, actually. And we are going to a few months ago, and we're going to talk about how this patient's case sort of unfolded for us with regard to ovarian disease. So our patient's initial EO is a 30-year-old Caucasian female, G0P0, with some history of bleeding between otherwise regular periods. She associates this with some lower back pain, which is sharp right versus right greater than the left. There's some interesting family history of prostate cancer in her father, breast cancer in her mother, age 68. She survived the breast cancer. The patient herself has had breast reduction surgery and has not yet started routine mammography. She does have an IUD, Mirena, placed a couple of years back, but continues to have dysmenorrhea symptoms in between. The Mirena was placed for contraceptive reasons. And so she's come to us and she's expressed on her patient intake form that she has plans to start a family soon in the next few years, and she's concerned about this irregular menstrual cycle that she's experienced. She does rely on Motrin 600 3 times a day for her period pains, and the Motrin itself is causing gastritis symptoms, and so she's also having to take antacids on her period. So right there, we've got a patient who's basically figured out how to manage her symptoms, but she's still sort of suffering and struggling through them, and she's looking for more answers. And as of right now, the irregular period bleeding could be enough to get her into a transvaginal ultrasound with her OBGYN. She has instead elected to come straight to us at Prenuvo. So she has no other specific investigation from dysmenorrhea completed. Her labs have showed some mild anemia. She is monogamous, no discomfort with intercourse. She's a vegetarian, BMI of 20.1. She exercises daily by jogging. And then her last pap smear was normal. Her pregnancy test has been negative. And no other irregular findings on her physical exam per her OBGYN, meaning her pelvic exam was really non-contributory, healthy cervical exam, a healthy pelvic. The only other interesting thing of note is that she admits to some milder symptoms of hirsutism on her face and arms, so a little virilization, acne that comes and goes with menstrual cycle, and she does experience these frequent bouts of hypoglycemia. So I've included that there, that she verbally says, "I get hangry a lot," which is a really common thing that we hear from all kinds of folks, especially our family members, right? Some pack a snack. So this patient has identified these, not necessarily drawing them into her dysfunctional uterine bleeding, but rather just to say these are other symptoms that she experiences. So it's generally kind of vague. So routinely, our diagnostic evaluation is going to include the physical examination. That is a pelvic examination primarily, as well as a physical assessment. So we're going to be looking for things like hormonally active masses like virilization, as I mentioned with our last patient. We're also looking for things like a mass that's irregular, fixed, or associated with cul-de-sac nodularity. Ascites or bloating is a symptom to look out for, abdominal distension, and certainly pain with palpation externally or internally. Lab testing is another feature of the workup, and we'll talk about that in just a moment. But I want to make sure that our folks here are also getting really detailed histories that kind of speak to ovarian disease. That would include, of course, your menstrual history, characteristics of the pain, fever, sexual history, and then the presence or absence of infertility, which, back to our case study, we don't really have known infertility as the patient's been on contraception. It's difficult to identify these symptoms. A majority of women with ovarian cancer and disease are going to present with just abdominal pain, followed by gastrointestinal discomfort, and then routine, recommendations or routine reports of pain. A smaller number will then report things as urinary symptoms or pelvic discomfort go. So it's actually a minority of ovarian cancer patients who will report pelvic-specific symptoms, which is really going to be confusing clinically, I think. The other risk factors for ovarian cancer are the genetic and the family history. Gene testing, if available, would indicate BRCA mutations, a condition named Lynch syndrome, which is a hereditary non-polyposis colon cancer, also increases risk of ovarian cancer. And then we're also looking for the BRIP, the RAD51C and D variants of that mutation. So those are on the genetic mutation side. And then certainly you've just got a detailed family history, which all of us should be able to collect, which would include looking for family history of ovarian or fallopian tube cancer, a history of infertility or endometriosis, a known history of cigarette smoking, which increases the risk of those carcinomas significantly, the presence of IUD, which again our case study has. And then you've got the use of oral contraception, past breastfeeding symptoms, and then previous pregnancies as well, or difficulty with thereof. So once we've moved on from detailed history and genetics, we can get a little bit deeper with imaging. The current recommendation is in conjunction with key aspects of the history and examination should lead to a very strong positive predictive value that a transvaginal ultrasound is going to yield some sort of a diagnosis. The definitive diagnosis, of course, has to be retained until we have pathology on any masses. So again, some sort of a surgical intervention or biopsy is often necessary to make a full diagnosis. But transvaginal ultrasound has been the mainstay traditionally for investigating suspected ovarian mass. This diagnosis may be made when adnexal mass is visualized on imaging ordered for other indications. So how often has it been that in our clinics we've actually encountered an ovarian mass as an incidental finding when investigating someone's abdominal pain with a CT scan, looking for something in their GI tract and actually finding something in the ovaries. So we've unfortunately relied on incidental findings to help manage the diagnosis of this condition, and of course we can do better than that. So that leads us to the idea of a non-contrast MRI. Adnexal mass characterization on non-contrast MRI has a high accuracy and excellent inter-reader agreement. The results of this 2021 study that I've listed here suggest that the preponderant value of a non-contrast MRI is its specificity because it provides confident diagnosis of many benign adnexal lesions. So MRI has a much higher specificity than even a transvaginal ultrasound. Women who clinically have a low risk of malignancy but have indeterminate lesions on ultrasound are the ones most likely to benefit from MRI as a second test option. However, it is reasonable at this point, considering the availability of non-contrast MRI, to start to consider it as an option for screening. CT scan, I should mention, is not a primary modality for evaluation of adnexal masses, that if you suspect someone with an ovarian mass, ovarian cancer, you should probably go from ultrasound to MRI if that's your traditional approach. A CT scan will not really give you the clear definitions that you're looking for to be able to characterize that mass. So bringing that back to our case study, we did perform whole body MRI on patient EO, and here's what we found. All the images are from that patient. Figure 4 in this slide is showing her IUD is in place and overall healthy endometrium. It measured about 5 millimeter thickness, which is within the normal range. And the uterus was well positioned, anteverted. Some no worrisome mass there in the uterus. The interesting findings were figures 5 through 7, which is where we find various sizes and locations of bilateral, simple, physiologic ovarian cysts. And these were characterized as simple ovarian cysts on the MRI. We had definitive characteristics there. They ranged in size between 1.7 centimeters and 2.3 centimeters in size. 2 on the right, 2 on the left were identified in these slides. So we've got multiple ovarian cysts bilaterally, measuring as large as 2.3 centimeters. And so we conferred a score of this patient to ORADS category 1, which is defined by these simple appearing ovarian cysts, very likely benign, very likely low risk. So that's probably best case scenario in terms of the rating. So let's talk about assessing the risk of malignancy here. We use the ORAD system as a way to assess the risk at a very quick level. The normal ovary, like we just mentioned, that last patient is an ORADS 1, followed by an ORADS 2, which has a risk of malignancy still less than 1%. So we really don't have a really high index of suspicion, even at a level 2. And that's going to include things like your hemorrhagic cysts and your dermoid cysts and endometriomas, anything less than 10 centimeters. And 10 centimeters becomes our magic number when we're talking about ovarian masses, so keep that in mind as we move forward. But anything less than 10 centimeters qualifies as a level 1 or level 2 ORADS. And then you've also got things like the paraovarian cysts, inclusion cysts, hyposalpinges. So those are all still category 2. Once we've reached level 3 through 5, this is when the risk of malignancy goes up significantly. And so these are the diseases that we're trying to catch a lot more early. And so, looking for that in women with ORADS 3 or above, they're far more likely to have surgery recommended for further investigation, given that risk of true positive, that 95% 5-year mortality for a stage 3 or 4 ovarian cancer. Right now, current clinical recommendations are to probably proceed to surgical intervention to remove the mass, or at least to biopsy the mass in order to get a full diagnosis. So we've got a fairly harmful procedure to investigate, but that's because the risk of not investigating is so darn dangerous. The other tumor markers and other lab tests that you may be considering when you identify a mass would be your CA-125. That is the most common tumor marker evaluated in patients with adnexal masses, and those are contingent upon an epithelial ovarian cancer. So the EOCs make up about 90% of ovarian cancers that have been detected, and that is, for your money, the most valuable test to get in conjunction with a suspicious set of symptoms in ovarian ultrasound. Other tumor markers to consider would be the HE4, the CEA, the CA19-9. If positive, these markers can be used for monitoring disease response to treatment as well. So again, you may not figure those out until you've already got some pathology back. And then patients with adnexal masses with symptoms or signs of estrogen excess, so the abnormal uterine bleeding, virilization, they're more likely to have your germ cell or sex cord stromal tumors, and those serum markers are listed here to the right. In many cases, the diagnosis of these, again, cannot be done until you've got full pathology of the ovary, of the mass. So it doesn't really make a ton of sense to start shooting off all these lab tests. If you were to pick one, it would be a CA-125. Even if the CA-125 is negative, it doesn't mean you're out of the woods. It's more of a true positive, not a false positive finding. Our other tools that we'll use include the multimodal test, the ADNEX model. ADNEX takes into account the patient's age, the treatment setting, believe it or not, the lesion diameter and solid cyst portion, the locules and the papillary projection numbers, acoustic shadowing on a vaginal ultrasound, and of course ascites and CA-125. So this is another tool used to kind of calculate the risk of a ovarian mass once you've been able to collect various points of data. The next couple of slides are very busy, but it's just to sort of indicate to us clinically that there are pathways now that have been separated for our non-pregnant premenopausal patients versus our pregnant or our postmenopausal patients. The idea here is that once you follow a patient's pathway down and you've gotten imaging, and then you may actually end up proceeding to CA-125 testing, you then have fairly clear recommendations on how to proceed. Most of these cases will end up in some sort of a surgical management because, again, of the high risk of potential malignancies. But, there is a process here for surveillance whereby either serial ultrasounding or, in our case, MRI might be useful to sort of manage these cases without having to do repeat procedures. So again, the next slide demonstrates that same set of procedures in place for postmenopausal patients. But again, I've presented these slides just more as a resource so that we understand that for different categories, there are different protocols that we can follow that should make pursuing these diseases a much more straightforward process. Thinking about the non-surgical interventions, there are procedures such as paracentesis, thoracentesis, depending on the location of masses and fluid, and of course omental, pleural, and lymph node biopsies. So image-guided biopsy of the ovary is not recommended, as incising or rupturing the mass can lead to spillage. So that really puts us in a predicament that we cannot do a simple biopsy of an ovarian mass directly because of the risk of it damaging and then spilling those those cells into the peritoneum. So we're again stuck with full surgical excision at that point. These are high-risk features to determine the intervention. In premenopausal patients, a CA-125 is most often associated with many conditions other than ovarian cancer. And so we actually use a different threshold for that. It's important to know that your CA-125 threshold needs to be over 200 units per milliliter in premenopausal, whereas in postmenopausal, we only use a cutoff of 35 units per milliliter. So the CA-125 has a poor diagnostic performance in the premenopausal category because of that large window of false positivity. In general, a large mass greater than 10 centimeters alone is not the indication for surgery in premenopausal patients as it is in postmenopausal. But in postmenopausal patients, a large mass size does increase the likelihood of them developing symptoms and making ultrasound assessment more difficult. So once you have a symptomatic patient, ultrasound itself becomes just a difficult procedure to achieve. So again, we fall back to ideas such as the MRI to help make that a more comfortable experience for the patient. Surveillance can be performed for premenopausal patients with a large adnexal mass that has no other findings suspicious for malignancy. So that leaves us then with the sex cord stromal tumors. And again, we're looking for those classic symptoms of hormone production like hirsutism and virilization, menstrual irregularities, precocious puberty. These are all higher risk indicators that indicate that your patient may have Peutz-Jeghers syndrome. There may be some thyroid dysfunction associated. That's something called Dicer-1 syndrome. And so these sex cord stromal tumors, these are large at diagnosis and they can even rupture, and that can cause the patient to have an acute presentation of hemoperitoneum. But then you've got the patients with almost certainly benign masses, and so these are going to be the physiologic cysts, the endometriomas less than 10 centimeters, and the hydrosalpinx. Just a quick word on hydrosalpinx. That's fluid blockage in the fallopian tubes that may make it difficult to become pregnant. So while clinically it doesn't have a large risk of mortality, any patient who is trying to get pregnant, any patients who are difficulty with fertility, diagnosis of hydrosalpinx can be incredibly helpful for the prognosis. And it's a simple procedure of draining and repairing those tubes to overcome that obstacle. We also consider the paratubal and paraovarian cysts, a broad ligament leiomyoma, which could be located adjacent to the ovary and fallopian tube as another potential mass. And then, of course, your mature teratomas, which, as long as they're less than 10 centimeters, are still considered benign. So while most mature teratomas are benign, surgery is indicated because diagnosis is just difficult to achieve without so. And we don't want to leave a potential endothelial carcinoma in place when it could be something much more dangerous, correct? So, walking through the pathophysiology, the determination of disease, I want to hand it over to Dr. Kanu, who's going to go through a few live cases that we've encountered at Prenuvo, and then I'm going to bring it back to that case presentation I was presenting earlier.
Hello and welcome again. I am Daniella Kanu, one of the staff radiologists at Prenuvo. I'd like to share some cases of the female pelvis with ovarian pathology, just tying together the clinical aspect of things with the imaging that we do see here. All in all, combining these two, we put together a differential for the reasoning of patient care. So this first case is a 73-year-old female with a suspicious right ovarian cystic lesion. Hopefully you can see the right arrow pointing to what looks like a mixed viscosity lesion in the posterior aspect of the right hemipelvis. It's about a 2 to 3 centimeter lesion, not particularly large on the grand scale of things. However, given the patient's age, we don't like to see cystic lesions of the ovary greater than about a centimeter. In a younger patient, this would probably be first thought of as a potential hemorrhagic cyst, physiologic, and not pathological, but in a 73-year-old postmenopausal patient, this raises concern for a potentially early disease pathway, and this would be in the epithelial cell line, such as a mucinous or serous cell line. This is a younger 45-year-old patient, has a few risk factors such as having children and long-term light smoking. What we see here is a moderate size, predominantly cystic lesion in the right adnexa, located in the right ovary. And size-wise, it would raise eyebrows even in a young patient because it's greater than 3 centimeters. It's about 5 to 6 centimeters. And what raises even greater eyebrows is this lesion contains a solid mural nodule that the arrows point to. And this is the tip-off for potential neoplasm. This would also be in the epithelial cell line, more likely to be a serous cell line lesion. There's also free fluid in the pelvis, and in a young premenopausal patient without pathology in the ovaries, that's completely acceptable and physiologic, either from bowel or from the internal genitalia. From the reproductive organs. However, given that there is pathology here in the right ovary, it would add to the suspicion in this case. Okay, this is a 65-year-old female, postmenopausal, has had a hysterectomy, doesn't have some of the other risk factors, no children, no smoking, found to have a sizable, about 5 centimeter solid lesion in the left adnexa, well circumscribed, slightly heterogeneous. But the significance of this is not only size, but it also shows a T2 dark appearance, which is not cystic. It is a solid lesion. And this T2 dark appearance leads us down the pathway, the germ cell fibromas, thecomas, fibrothecomas, and such lesions. Actually, not the germ cell, the sex cord tumor pathway. And the size raises concern for potential ovarian torsion. So this would be looked at as pathological. This is a 58-year-old female, asymptomatic, postmenopausal, has had 3 children, found to have a complex left ovarian cystic lesion, not particularly very large, but it is complex. And again, in a postmenopausal female, anything greater than 1 centimeter, anything with internal complexity raises suspicion. And the significance of this case would be, even though given it's a smaller size, would be that if it were pathological, we have isolated it in an earlier stage of disease. This would be in the epithelial cell line, so serous or mucinous cell type, most likely. This is a young 38-year-old female, asymptomatic, who came in for a Prenuvo scan, has a history of intrauterine device, 2 children, and no smoking history. Found to have a very large, greater than 10 centimeter, predominantly cystic lesion extending from the pelvis into the lower abdomen, so quite large, even though the patient was asymptomatic. It is complex in appearance, containing multiple thin internal septations, kind of web-like, and this would also be suspicious for an epithelial line lesion. This case, although it's large and it looks like it's centered in the center of the pelvis or midline pelvis, brings home the point of how important MRI could be to isolate the exact location. And in lesions this big, although our first line imaging for female pelvic pathology is the ultrasound wouldn't be able to appreciate the extent of this lesion given that it's so large. So the MRI is very helpful in seeing the lesion in its entirety and also tracking its potential origin, and this was tracked to the ovary or adnexa, and this would also be in the first line of thought epithelial cell line, probably a mucinous adenoma or serous, but most likely probably a mucinous. This is a 73-year-old female, postmenopausal, has a history of uterine fibroids and endometriosis, 2 children, long-term light smoker for over 50 years, many risk factors for developing ovarian pathology, including the endometriosis and fibroids. What we have found here in the anterior right pelvis is a pretty small, probably about 2 centimeter, but mildly complex cystic lesion of the right ovary. And again, the significance of this in a patient with this history is detecting early stage disease, particularly given that this would be most likely asymptomatic. This is a pretty young 28-year-old female, asymptomatic, no children, no smoking, found to have lesions on both ovaries, so bilateral ovarian lesions. It's a busy slide and hard to see, but if you'll bear with me, on the image to the far left, there is a red arrow pointing to a well-circumscribed dark spherical or ovoid lesion. That is of the right ovary, and it's a bit complex, heterogeneous in appearance. The images in the middle of the screen help to sort out what the lesion from that right ovary could be, and these are fat saturated on the top as well as T2 on the bottom. The combination of these images demonstrate that this lesion contains fat, and that is one of the three we think of adnexal lesions when we first see them on imaging in three directions. Is it cystic? Is it solid? Does it contain fat? Because this drives our thinking in different directions, and this contains fat. So this lesion was consistent with a mature teratoma, otherwise known as a dermoid, and this would be in the germ cell line. They are benign lesions with a very small chance for malignant degeneration. And then to the right of the screen, we have two images, top and bottom, displaying a very dark circumscribed lesion in the left ovary, so a contralateral ovary on T2. And if you can think back to a couple cases ago where we saw this solid appearing dark T2 lesion, it took us down the line of fibroma, fibrotecoma. This is similar. And the lesion on the image on the bottom shows us that lesion stays bright on the fat saturated sequence. So what that tells us is it does not contain fat. It is not in the same category as the dermoid, and this is more containing hemorrhagic products. So this lesion is actually more consistent with a endometrioma in the left ovary. So this patient is found to have two benign lesions on the right, the dermoid, and on the left ovary, the endometrioma. So benign and expectant in a patient of this age. Now, if we had bilateral ovarian lesions in an older or postmenopausal patient, and depending on their features, you start to think down more of a neoplastic or malignant pathway, things like lymphoma, metastasis, things like that. Thank you.
Thank you so much, Dr. Kanu. Those are incredible images. Just seeing the sheer size of those masses and the possibility that a patient would potentially be walking around with that and not get it investigated until late stage is really sort of just an indictment of how poor our current guidelines are and how much more proactive we need to be as a medical community. So I'm going to finish up the presentation now, just finishing on the kind of topics of what our actions would be around these findings. One of the first ones I mentioned was surveillance, active surveillance, and that includes, in many cases, one or more pelvic ultrasounds or non-contrast MRI, and measurement of serum tumor markers to sort of assess progression over time. There is no consensus regarding the best approach in various surveillance frequencies. In general, repeat imaging, these neoplastic cysts are going to enlarge, non-physiologic cysts are going to remain unchanged or enlarge slowly, and then physiologic cysts may actually resolve over the period of surveillance. So just frequency ideas are going to be for patients with an intermediate risk mass, an ORADS 4, and none of the other indications for surgery. There is the postmenopausal patient with a transvaginal ultrasound CA-125 every 6 weeks, 12 weeks, and then every 3 to 6 months for a year. And then a final ultrasound and CA-125 are performed one additional year later. And then for your premenopausal patients, we have a 6-week surveillance recheck to visualize that mass at various points in their menstrual cycle. And then there's a 3-month recheck, and then a 6-month recheck, and then finally an ultrasound 1 year later. So again, I want you to put yourself through the experience of being a female patient and to understand that these really frequent periodic rechecks on transvaginal ultrasound are physically probably very uncomfortable. And so we again would lean on the idea of implementing the MRI process to help us with that surveillance process. Really quick mention on the premenopausal patients. The CA-125 level is not routinely repeated in all those cases. If the 125 level was less than 35, we're probably not going to repeat it. It's really those cases where it's moderately elevated between 35 and 200 that we're going to want to repeat the CA-125 with each additional imaging set. And then for most premenopausal and postmenopausal patients with a low risk mass on imaging, that's an ORADS 3 or below, none of the indications for surgery described above, just a simple transvaginal ultrasound in 3 months, and then in 6 months is the current recommendation. You could potentially supplant that with an MRI in 3 to 6 months if you can get those done. So again, I want to bring this back to our case study patient EO, the 30-year-old female with an IUD who's thinking about trying to get pregnant. She's having some menstrual bleeding in between her periods, but it has not really been, intensely assessed. And so now we've done her whole body MRI, and we've discovered that she does have what we're considering polycystic ovarian disease. Again, with a BMI of 20, very, very difficult to catch those when we're looking for the classic obese females. That this is a patient who I'm assessing as a lean PCOS, which if you haven't had a chance to encounter are incredibly tricky to assess. But she's got the virilization, she's got the dysmenorrhea, and she's got the classic MRI findings, and that gives her enough criteria to fit that diagnosis. So her simple cysts, all less than 5 centimeters. There was no recommendation for an immediate follow-up imaging test, no recommendation for any lab testing CA-125 that she fell into the ORADS 1 category. So instead we leaned into lifestyle modifications with her. We talked to her a little bit about intentionally gaining some muscle mass, which if you are familiar, the idea of muscle mass is going to be an improvement of glycemic control in patients, and it's going to help them regulate blood sugars, which is part of the hormonal cycle for PCOS. Her hypoglycemic episodes seem to have dramatically improved by implementing modifications to her nutrition and exercise, cutting back on simple sugars and modifying her carbohydrate consumption. And she states that both her hair quality and acne since the time of her scan and recommendations are already getting better. That's nice. What's more important is that she is starting to take active maneuvers using over-the-counter supplements, which, questionable as they are, we've got some pretty good research now indicating that alpha-lipoic acid and myo-inositol are really well-tolerated supplements that have true data behind them indicating that they can be helpful for conception improvement, fertility, as well as managing the signs and symptoms of PCOS. So she's going to continue her Mirena IUD. She's using these supplements and these lifestyle modifications, and then she does plan to remove the IUD when it's time to try and conceive a family. Another interesting note is that her menstrual pain and bleeding seem to have significantly dropped, and she's no longer relying on the Motrin 600 and the antacids. So again, we've now spared her taking those medications. We've replaced them with supplements. Arguably, that's apple for orange there. But the benefits now are going to be tenfold in terms of her general health predisposition. So repeat ovarian cyst imaging is still pending in this patient. Electively, if symptoms persist or worsen by transvaginal ultrasound or via OBGYN or routine observation by whole body MRI, we're probably going to repeat that in about 9 months. In our general population, so when you have gone through a surveillance period, when do you stop and switch over to surgery? And that's going to be these things I want to leave with you. The mass develops high-risk frequencies of malignancy. The mass has increased in size greater than 10 centimeters, or your tumor markers are, the CA-125 in particular, has gone over 35 in your postmenopausal or over 200 in your premenopausal patients. And then if the mass remains unchanged or decreases in size and 125 levels remain stable, surveillance should continue until planned stopping point is reached. If the mass resolves, we can discontinue surveillance right there. But serial imaging is strongly advised to evaluate patients with a deadnexal mass, and that is indeterminate for low risk for malignancy. So again, serial imaging, think about your patients, think about their comfort with an ultrasound versus an MRI. There are benefits there, both diagnostically as well as comfort level. Very last couple of slides are just a summary of recommendations here that for your urgent conditions, that's a no-brainer. We need to get these patients emergency evaluations. That's when they have the acute pain, ovarian mass, significant bleeding, really at risk of ectopic pregnancy and torsion. Those will probably require urgent surgical intervention. Otherwise, your next few steps when you assess ovarian masses are going to be malignancy risk, that using the ACR guidelines, that we're still using the ORADS categorizations, If you fall at 1 or 2, you're okay to just kind of observe. At 3, you're probably doing serial surveillance. At 4, you're potentially looking at surgeries. And 5, of course, you should be thinking about surgeries. And then the very last slide here is the almost certainly benign masses, those low categories, ORADs 1 and 2. Those can be managed with analgesics, anti-inflammatories like our patient EO. You should reserve surgical management for those patients with any of those following symptoms, which would include any urgency that develops, anything that looks like mature teratoma, virilization symptoms, and then any patients who may have hydrosalpinx and they're thinking about doing IVF. This is another key indication for the idea of doing ultrasound or MRI, is you've got patients who are struggling to conceive, and we can now offer them a potential treatment through hydrosalpinx surgery, and that's going to allow fertility to occur. And then surveillance, performed for patients with low and intermediate risk masses on imaging. No other indications for surgery. The risk of malignancy in these patients remains low.
I do see a question here from Sarah. So does it make any difference in the images on the strength of the MRI machine, example 1.5 versus 3 Tesla?
And Dr. Kanu may want to chime in here. My understanding is that the image resolution on a 1.5 actually gives us a better indication for true severity than the 3 Teslas. The metaphor that's been used for me is that it's sort of like a 3 Tesla coil is sort of like having an HD TV, but still getting old reception, that the pictures just don't look quite right, and we don't really get the clarity of image that we're trying to achieve. I think Dr. Kanu has kind of echoed that there in the chat. Yeah. Any other thoughts on that, Daniella?
No, I completely agree with you. People tend to think that the higher the number, the better the images. It's actually not the case. 3 Tesla leads to a lot more artifacts. They tend to have a lot more artifacts. 1.5 is what is generally used around the country, around the world. And we tend to use the 3 Tesla for specific questions we need to answer in research, actually. It's more utilized in research.
Thanks.
Cool. All right. We'll leave it at that. Thank you so much for your time today. Thank you, Dr. Modi. Thank you, Dr. Kanu. And enjoy the rest of your week.
Pleasure. Thank you.
Thank you.